And here is addiction. Addiction is when you're taking it recklessly and in a dangerous way and showing signs of obvious problem. And then you have patients, people that are not pain patients. People aren't really stealing the blood pressure medicine, and they're not stealing diabetes medicine. You know, it doesn't happen, so you don't have to worry about it. But when we prescribe pain medicine, we know that people are going to try to steal a certain amount of these medicines, or they could get into the wrong hands, or that even someone could be not being honest in the doctor's office about why they're there. And so these are the non-medical users of the pain medicine. And this is the same thing. Maybe they are treating something else, depression, anxiety, or something, or maybe they're just doing it for fun, recreation, or they could be addicted and substance abusers. So you have addiction and substance abuse in both pain patients and non-pain patients. This we consider a dual diagnosis, a pain problem with a substance abuse problem. And this is an epidemic now with the prescription drugs. The U.S. prescribes more prescription drugs than the rest of the world combined. And pain medicine is abused number 2 after marijuana. So you think about like cocaine and stuff like heroin, you know, it doesn't come close to pain medicine. So prescription drugs, the number 1 drug, hydrocodone, Vicodin. That's by far the number 1 drug in the world prescribed. And you can see the numbers. This is Lipitor. This is in 05-06. I'm pretty sure that in 2009, 2010, Lipitor is still number 2. And it's going to be generic soon, so it might get up a little higher after that. But it's not close to hydrocodone. And so hydrocodone is the number 1 drug prescribed in the country by far. Next. This I talked about a little bit, misuse, abuse, addiction, dependence. We have this conversation a lot in the office about dependence. I'll just skip to the bottom. These are problems. Dependence isn't. Dependence is a fact of life that comes with pain patients that need pain medicine. If you take a pain medicine around the clock, meaning all day long, and if you take it every day around the clock, your body becomes dependent on it. In some people it could be in a week, and in some people it could take years, and not every patient becomes dependent, although the most people do. That doesn't mean you depend on it to survive. That means you'll get sick if you forget to take it or if you run out. And that's dependence. And that is not a sign of addiction, although people that are addicted can be dependent. People that are not addicted can also be dependent. Dependence is a fact of taking medicine and exposing yourself to the medicine around the clock. And that's not necessarily a bad thing. And we have this conversation with patients a lot. Because people say, I don't want to become addicted. I say, how old are you? 85. Did you ever have a problem with drug addiction in your life? No. Alcohol? No. Cigarettes? No. Chocolate? No. I say, well, the odds of becoming addicted at age 85 with no history of addiction are close to 0. Could it happen? Yeah. But if you make it 85 years, that's the last thing you got to worry about. But you could become dependent. If we give you a long-acting medicine, or if you take your pain pill every 4 to 6 hours every day, odds are that if you forget it, you'll feel a little sick. Or if you run out and lose it, you'll get a lot sick. That's dependency. So is chronic pain medicine effective for chronic pain? There's really not good studies that prove that. We know that it works for a lot of people. But what we mean is it effective? If you give it to populations, you give it to thousands and thousands of people, is that going to be a great idea? No one studies it because there's no point to study it. It's happening and you can't take it away. You can tell patients, well, it's not effective. It's not fair to not treat pain, and we know this works. It's like the parachutes work for skydivers. I mean, no one studied it, okay? They don't need to. It works, but it is important to know that we haven't done long-term studies to see exactly when is the time to stop or to change or to transition or to do other things besides the pain pills. So really we do need to study how do we give these chronic pain medications and what do we do in the long term more, and those are things that are not studied at all. The FSMB is the Federation of the State of Medical Boards, and this is the policy, is that patients should be treated for pain, okay? Pain management is important. It's important and integral to the practice of medicine. The FSMB says pain medicine's okay. You know, your doctor could say, oh, no, I don't prescribe pain medicine. And a lot of doctors say that now because they're uncomfortable with the other problems, abuse and misuse and addiction, and they're just not comfortable. But the FSMB says we should do it. We should prescribe pain, but we should also be careful what we're doing. You know, we have a responsibility to minimize abuse and diversion. The physician is not the police department, and we are not pretend to be police, but we have a responsibility, and that's the fact. We should do it, but we should be careful about it. Next. So non-opioid therapies do exist and are effective and may be overlooked. They are sometimes preferred for chronic pain management, at least to, if not to get patients away from pain medicine, to reduce the need for higher and higher doses and ever-increasing doses every office visit. And pain management specialists can help to identify what those treatments are. The reason I put the back pain in, because I had this presentation that included back and osteoarthritis. Those are the two most common causes of pain. Osteoarthritis is actually #1 cause of disability in the world. Okay, osteoarthritis. Everyone has osteoarthritis. It's not always a disease. Osteoarthritis is wear and tear of the joints. And back pain seems to be more of a problem leading to the chronic pain syndrome and problems that we see with patients dealing with pain. But we do see a lot of arthritis. We have specialists in arthritis. I do take care of patients with osteoarthritis, and there's a lot we can do non-operatively. But for osteoarthritis, you have some good curative procedures. Joint replacement, shoulder, knee, and hip replacement works very well. And we can do other things like bone fusions for joints that we can't replace that work in certain situations if you broke your ankle or something, or certain bones in the hand, although they all have their limits. The joint replacement is really revolutionized the treatment of arthritis, and we have specialists that do that for a living in our office. Back pain is the biggest pain complaint, though, by far, that patients have. And probably in my practice, it's probably 60 or 70% back pain and 20% arthritis and 10% neck if you want to separate the low back from the neck. So we see a lot of arthritis and a lot of neck, but this is the big thing every day, nonstop, is the low back pain. And because it's 80% of adults get episodes of back pain in their life, and 4% a year adults will have it, 8 to 10 million people will go to the doctor for it each year or more. And it is a high cause of disability as well. When we break down, again, the lumping and splitting, a back pain patient comes in, we say, okay, is it just their back or is their back and leg? And that's the first kind of distinguishing thing that we look about. Back pain itself, when it's really just in that sweet spot in the low back, that's the holy grail there of pain management. Or sometimes when this is really bad, it starts to go down here a little bit, but not necessarily just shooting down. We call that mechanical low back pain or axial low back pain. And that's often a sign that there's a cushioning problem. That's a common problem in the degenerative process, and that's mechanical back pain. The second group is the leg pain patients. That leg pain, a lot of patients call it sciatica because the sciatic nerve, they know, it's the biggest, most famous nerve in the body, in the world, the sciatic nerve. But usually it's not a problem with the sciatic nerve, it's a problem with the nerve root in the back. And this is a picture of a patient who has a cartoon that has a disc herniation. These little dots there are the nerve roots as they go down the spine. This is a bird's eye view down, and this is the individual nerve root coming out, and this shows a disc. And the little piece of the disc, the soft center, is like the jelly in a donut, has popped out and is hitting this nerve root and irritating it. And this could cause pain in the back, but usually is going to cause pain straight down the leg, depending on which nerve it's touching. And so sciatica is a very common cause of pain from a lumbar disc herniation. The next one. You can feel like a lot of people, they don't have back pain. They just have leg pain. They say, I pulled a hamstring or I have these cramps. I don't know why. Very rarely, if that disc herniation or if that problem is very big, you can have bowel and bladder problems. You don't recognize this from the back. Okay. Or you can have weakness, neurologic loss, pins and needles, falling asleep situation. Spinal stenosis and herniated discs do occur in adults. We just don't see them as frequently, or I'm sorry, not in adults. In patients over 50, we don't see the disc herniate out as frequently over 50 because the disc is, like I said, it's the degenerative process. The disc tends to calcify a little bit and harden, so that soft part tends not to squirt out. Plus, as we get older, it becomes less soft. But you have some people that have perfect looking discs and they're 90 years old and out pops the disc herniation and you say, I'm surprised. And so we do see older patients than 50 with disc herniations, but the more common thing we see with leg pain over 50 is stenosis, and that's crowding of the nerves, not individual nerves, and it's usually down both legs. When you stand and walk, you feel it, and you sit down and you can make it go away, and you know, I can only stand and walk for 10 minutes, or I have to use a grocery cart, and that helps, then I can do 20 minutes or 30 minutes or whatever, and that's spinal stenosis, and that's this crowding. You see this is one of those discs that I was talking about that's hardening, it's getting flat, and it's getting bone spurs pushing into the nerves as they come down. This is your back, a profile view there.